Assalamu alaikum. Good morning, respected faculty and colleagues. I am Dr. Syed Sheraz Ali. Today, I will be presenting on renal trauma, focusing on its definition, classification, evaluation, imaging, and management according to current trauma and urology guidelines. Trauma is defined as physical injury or wound to the tissue caused by an external agent. Worldwide, trauma accounts for more than 4 million deaths annually, constituting nearly 8% of all deaths. According to the World Health Organization, trauma injuries are classified into intentional injuries such as interpersonal violence, war-related or self-inflicted injuries, and unintentional injuries which may include ATLS, falls, and domestic accidents. Trauma can also be classified based on the mechanism of injury into blunt and penetrating trauma. Penetrating trauma is further classified based on projectile velocity into high velocity, medium velocity, and low velocity injuries, such as stab wounds. Now, going toward the evaluation of patient with abdominal trauma, the patient are assessed after initial resuscitation and categorized as physiological normal, physiological non-compromised, and physiological compromised. This categorization determines the extent of the investigation and urgency of surgical intervention. Now, let's go toward the zones of the abdominal cavity. And according to the trauma, it is divided into three zones: zone 1, zone 2, and zone 3. This zone 1 is the central zone, and it should always be explored. It is a surgical emergency. Then zone 2 is should be only be explored if it is expanding or pulsatile or penetrating injury is present. And zone 3 is pelvic. As with zone 2, they should only be explored if they are expanding or pulsatile or penetrating injury is present. Pelvic hematomas are exceptionally difficult to control and whenever possible should not be opened. They are best controlled with compression or extraperitoneal packing. And if the bleeding is arterial, then angioembolization is a better approach. Now going toward the renal trauma. Uh, Renal trauma occurs in approximately 5% of all trauma cases. It is the most commonly seen in young males. On arrival of trauma patient, they are managed according to a ATLS protocol with priority given to airway, breathing, and circulation. The most widely used classification system for renal trauma is American Association for the Surgery of Trauma, which is AAST classification. This system is validating and predicts both morbidity and need for intervention. Currently, most grade 1 to 4 injuries are managed conservatively. This is the This slide demonstrates the AAST grading system for renal injuries ranging from grade 1 minor contusion to grade 5 shattered kidney or renal vascular eversion. In grade 1, there is subcapsular non-expanding hematoma or parenchymal contusions. In grade 2, there is the non-expanding hematoma confined to the geotaphasia or renal parenchymal laceration less than or equal to 1 centimeter depth without urine extravasation. In grade 3, there is laceration greater than or equal to 1 centimeter depth without collecting system rupture or urine extravasation, or any injury in the presence of a kidney vascular injury or active bleeding contained within geotaphasia. In grade 4, there is parenchymal laceration extending into the urinary collecting system with urinary extravasation. Renal pelvis laceration or complete ureteropelvic disruption, or segmental renal vein or artery injuries. In grade 5, there is shattered kidney with loss of identifiable parenchymal renal anatomy or main renal artery or vein laceration or avulsion from renal hilum, which is devascularization kidney with active bleeding. This is the graphical illustration show the progressive increase in severity from grade 1 through grade 5 renal injuries. This is grade 1, which is contusion or subcapsular hematoma without laceration. say grade 2 injuries, and you can also see on the right side of the CT and also in the pictures, which is superficial cortical laceration less than 1 centimeter without urinary extravasation. This is the grade 3 in which laceration greater than 1 centimeter without involvement of the collecting system. This is grade 4 laceration involving the collecting system or segmental vascular injury. And this is a shattered kidney, avulsion of the renal hilum. Now going toward the symptoms and signs of the renal trauma. Common clinical features of renal trauma include flank pain, flank bruising, hematuria, abdominal tenderness, and features of shock and severe injuries. Hematuria may be microscopic or gross. However, the degree of hematuria and the severity of renal injury do not correlate consistently. Now going toward the evaluation of the patient. Evaluation of stable patient follows a structured trauma protocol. History should include pre-existing renal disease or solitary kidney. Examination may reveal flank bruising or penetrating wound. And investigation include urinalysis, hematocrit, serum creatinine, past scan, and CT scan with IV contrast, which is the gold standard. Past scan is the primary survey of the critically injured patient. Past, which stands for focus assessment, sonography, and trauma, is used to identify hemoperitoneuum as the cause of hemorrhages and hypovolemia. It is not routinely used for the assessment of solid organ injuries, as it is insensitive, operator dependent, and does not define the injury well. And it is inferior to the CT, but it is an option for follow-up. Intravenous pyelography, which is the gold standard. The intravenous CT scan with IV contrast is the gold standard, and if patient is stable, then we should proceed with this. Now, imaging aims to grade renal injuries, detect pre-existing renal pathology, confirm contralateral kidney, and identify associated injuries. Indication include gross hematuria, microscopic hematuria with hypotension, high velocity deceleration injuries, penetrating trauma, and clinical signs suggestive of renal injuries. Hemodynamic status will determine the initial imaging pathway with unstable patient, potentially requiring immediate intervention. The majority of patients with moderate to major trauma will have a CT scan performed soon after presentation. CT scan with intravenous contrast is the imaging modality of choice in stable patient. It is ideally performed in 3 phases: arterial, nephrogenic, and delayed phases, to assess vascular, parenchymal, and collective system injuries respectively. But in practice, trauma patients usually undergo standardized whole body imaging protocol, and delay phase imaging of renal tract is not routinely performed. If there is suspicion that renal injuries have not been fully evaluated, delayed phase imaging is recommended. The rate of contrast-induced nephropathy seen in trauma patient is low. Now going toward the management, if the patient has, it is the hemodynamic stability is the most important determinant of management. Non-operative management is preferred in stable patient and includes bed rest, serial hematocrit observation, and repeat imaging if indicated. The non-operative management of renal trauma can be viewed as package of care, a stepwise approach starting with conservative treatment followed by minimally invasive and or surgical exploration if necessary. It should be noted that an algorithm for package of care will vary in different centers according to available interventions. However, the importance of escalation in the treatment intervention should be emphasized. This approach has likely resulted in the rate of nephrectomy for high-grade renal injury decreasing over time. This is the graphical representation of the management plan. This is the management summary. Grade 1 and 2 injuries are managed conservatively. Grade 3 injuries are usually managed conservatively unless laparotomy is required for associated injuries. And grade 4 and 5 injury usually require surgical intervention. Now going toward the blunt trauma management. Grade 1 and 2 are managed non-operatively. Grade 4 mostly treated conservatively, but the requirements for subsequent intervention is higher. Persistent urinary extravasation from an otherwise viable kidney after blunt trauma usually responds to stent placement or percutaneous drainage. And sometimes the blunt trauma often present with a hemodynamically instability and major associated injury. This is a higher rate for exploration and nephrectomy. Risk factor increase risk factors that are increasing the risk for intervention include large hematuria, the large hematoma more than 12 centimeter, contrast extravasation, renal extensions, associated injuries, and shock. Now going toward the management of the penetrating renal injuries patient. Penetrating abdominal wounds have traditionally been managed surgically. However, selective non-operative management of penetrating abdominal wound is now accepted following detailed assessment in stable patients. Uh, the low-grade stab wounds posterior to the anterior axillary line can be managed non-operatively in stable patient. Grade 3 or higher injuries due to stab wounds in the stable patient can be managed expectantly but warrant close observation as the clinical course is more unpredictable and associated with a higher rate of delayed intervention. The majority of high-grade injuries concerning concomitant abdominal injuries and gunshot wounds are most likely to fail non-operatively management, and so surgical intervention is required. Overall, non-operative management of penetrating injuries in selected patients is associated with successful outcome in up to 50% of stab wound and up to 40% of gunshot wounds. A gunshot wound is an independent risk factor for nephrectomy in grade 4 and 5 traumatic renal injuries compared with stab wound. Now going toward selective angioembolization. It plays a key role in the stable patient with active bleeding. Indication include the active contrast extravasation, pseudoaneurysm, and AV fistula. Uh, it has been utilized in non-operative management of all grades of renal injuries, and it is likely the most beneficial in the setting of high-grade renal trauma, AST greater than 3. There is a successful rate of 94.9%, 0.9% in grade 3, 89% in grade 4, and 76% in grade 5 injuries. Increasing rate of renal injury is associated with increased risk of failed angioembolization and need for repeat intervention. Gross hematuria, hemodynamic instability, grade 5 trauma, and urinary extravasation are significant predictor of angioembolization failure. Repeat CT imaging is indicated in a patient with fever, unexplained drops in hematocrit, flank pain, high-grade injuries, or penetrating trauma. Now going toward the indication for renal exploration, which is persistent hemodynamic instability, grade 5 vascular or penetrating injuries, and expanding or pulsatile perirenal hematoma. The goal of surgical or vascular control and renal salvage. A transperitoneal approach is prepared with early control of the renal pedicle. Uh, in this exploration transperitoneal approach, we enter the retroperitoneal. There are some notes regarding the management. Stable hematoma detected during exploration by surgery injuries should not be opened. Central or expanding hematoma indicate injuries of the renal pedicle are aortic or vena cava and are potentially life-threatening and warrant further exploration. Renal reconstruction should be attempted if the hemorrhage is controlled and there is sufficient viable renal parenchyma. Renotherapy is the most common reconstructive technique. Partial nephrectomy is required when non-viable tissue is detected. And what diet closure of the collecting system is desirable, although closing of the parenchyma over the injured collecting system is acceptable. Repair should be attempted in a patient with solitary kidney or bilateral injuries, and nephrectomy for main artery injury has outcomes similar to those of vascular repair and does not worsen post-treatment renal function in the short term. Now going toward the complications. The early complications include bleeding, infection, perinephric sepsis, urinary fistula, hypertension, and urinary extravasation. And delayed complications include bleeding, calculus formation, chronic pyelonephritis, hypertension, AV fistula, and hydronephrosis, and pseudoaneurysm. Thank you for the listening. I will be happy to take any question.